Our data have suggested that a 3-portion right ventricle with a tricuspid valve diameter above the lower 99% confidence limit can safely be used to support the pulmonary circulation. This would also apply to patients whose Z value of the tricuspid valve diameter is minus 1.5 or more. Patients who fulfill this criteria either since birth or as a result of a satisfactory decompression will undergo radical repair leading to a biventricular circulation. The operation consists of relieving any residual right ventricular outflow tract obstruction and closing the atrial septal defect and the extracardiac shunt if present. Some or all of these procedures can be sometimes carried out by interventional cardiac catheterization. Recruitment of the right ventricular cavity by excision of hypertrophic muscle or both the trabecular and infundibular portions may render some ventricles suitable for biventricular repair. An outflow tract patch enlargement or homograph valve placement may be necessary in some patients. If tricuspid valve regurgitation is present, repair of the tricuspid valve is undertaken. Patients whose decompressed right ventricle has not grown sufficiently to provide a right ventricular dependent pulmonary circulation can benefit from a variety of procedures. If it is believed that the right ventricular cavity is large enough to deal with 2/3 of the systemic venous return, the superior vena cava can be connected to the right pulmonary artery, classical Glenn procedure, and the inferior vena cava blood can be diverted to the left pulmonary artery via the right ventricle, following complete relief of any residual right ventricular outflow tract obstruction. The atrial septal defect should ideally be closed to separate completely the systemic and the pulmonary circulations. Because of the known complications, we no longer perform classical Glenn. Now we will see this figure 28.2. In A version, this is the CVG to right pulmonary artery, the classical Glenn, and all the blood from the inferior vena cava is going to right ventricle to the left pulmonary artery. An alternative approach for the creation of a 1.5 ventricle circulation suggested by Billingsley consists of performing a bidirectional cavopulmonary anastomosis, inserting a homograph in the right ventricular outflow tract and closing the atrial septal defect. And in the right you see this figure 28.2, and this is the bidirectional cavopulmonary anastomosis. This is the homograph in the right ventricular outflow tract, and also the ACD has been closed. This is 1.5 ventricular repair. The ACD can also be left partially opened with a small defect created central in the patch, so that at a later date closure with a device would be possible. Alternatively, an adjustable atrial septal defect can be used. And now see in the right figure 28.3, this is the hole in the atrial septal defect. The theoretical concern about 1.5 ventricular repair is that in ventricular systole the peak pulmonary arterial pressure can be higher than the superior vena cava pressure, thus producing systemic venous hypertension with retrograde flow in the superior vena cava. Incorporating too small a right ventricle in the circulation can become more a hindrance than a benefit, and the Fontan type of procedure might be preferable. Repair of right ventricular outflow tract obstructions in children. There is no unanimity concerning the level of right ventricular systolic pressure at which relief of right ventricular outflow obstruction is indicated. In general, pulmonary stenosis is well tolerated and the risk of sudden death is much lower than with obstruction to the left ventricular outflow. A cooperative study recommended surgery in children with gradients greater than 50 mm mercury. The advent of transcatheter balloon valvoplasty has reduced considerably the number of patients who require surgical treatment for isolated pulmonary valve stenosis. For balloon valvoplasty, the combination of right ventricular hypertrophy and the peak velocity of 4 meters second would encourage most cardiologists in the United Kingdom to intervene. Operative techniques: pulmonary valvotomy, valvectomy under inflow occlusion. This procedure is usually carried out at normothermia through a midline sternotomy. Details of surgical technique are illustrated in figure 28.4. An incision is made and pericardial stage sutures are inserted as usual on the edges of the pericardium. Tapes are placed around the superior and inferior vena cava. A suture tied around the tip of the on the left atrial appendage is used to keep it away from the anterior aspect of the pulmonary artery. The aorta and the pulmonary arteries are not dissected apart. A side biting clamp is then placed on the main pulmonary artery, onto which a longitudinal incision of about 1 cm in length is now made. Two stage sutures of 6,0 polypropylene are then placed on the edge of this arteriotomy incision. Now we are going to look at figure 28.3. Yes, this is the clamp, and now we are going to read the next. It is important to emphasize the details of preparations made for inflow occlusion. The patient is hyperventilated with 100% oxygen. Sodium bicarbonate is given to counteract the metabolic acidosis that may develop during the arrest. The inferior vena cava and superior vena cava tapes are snagged. When the systemic arterial pressure falls to 30 or 40 mm mercury, a large side biting clamp is introduced into the transverse sinus so as to occlude the ascending aorta and the bifurcation of the pulmonary artery in which a way that the flow from the ductus arteriosus to the pulmonary arteries is interrupted. If the ductal flow is not interrupted during the period of inflow occlusion, blood will continue to flow from the aorta into the pulmonary arteries, from there into the left atrium, then into the right atrium through the patent foramen ovale, and then into the right ventricle and the pulmonary artery, thus allowing blood to pour through the pulmonary artery and making the valvotomy difficult. The valve is opened as widely as possible. If the valve is very dysplastic and remains obstructive in spite of the valvotomy, the cusps are excised. The caval tapes are then released. The lateral stage sutures are held so as to place the side biting clamp on the main pulmonary artery. The side biting clamp placed into the transverse sinus is released and the pulmonary arteriotomy incision is closed with a running suture of 6,0 polypropylene. If pulmonary blood flow is still felt not to be satisfactory after the valvotomy, a modified blood octanosing shunt can be added during the same procedure. Relief of right ventricular outflow tract obstruction on cardiopulmonary bypass. A midline sternotomy incision is made. A patch of pericardium is harvested if a patch enlargement is expected to be required. Woven pericardium or a Gore-Tex patch can also be used. The pulmonary trunk and the aorta are separated from each other by sharp dissection so that the aorta may be cross-clamped without impinging on the pulmonary artery. The aorta is cross-clamped because there is an ACD. The usual techniques for cardiopulmonary bypass are used. Hypothermic cardiopulmonary bypass is initiated. The degree of hypothermia depends on the expected length